So it's 10 a.m. on my computer. Good morning and welcome to the Primary Health Network's Male Suicide Prevention Symposium, hosted by the Australian Men's Health Forum as part of our June online summit, which is called Men's Health Connected. I want to start by acknowledging the traditional owners of the lands where we're all meeting from today, all over Australia, and some people also overseas. I want to pay my respect to the elders, past, present, and emerging, to acknowledge any Aboriginal or Torres Strait Islanders in the Zoom room with us right now or at any time during the day, and also acknowledge that it's National Reconciliation Week. And as someone who lives in a part of the country where 250 years and a couple of days ago, Captain Cook first put his foot down on Queensland soil, I am personally very aware of the significance of this time of year. So, welcome. For those of you who don't know, I'm Glenn Poole and I'm CEO of the Australian Men's Health Forum. Thanks for everyone who's registered to attend today. I can see that the number of participants is creeping towards 100. I just really want to encourage you today to see this as an opportunity to have a conversation and participate. We're all in a room together on Zoom here. It's not one of those setups where it's a webinar and there's the speakers and the attendees are looking in from the outside. So if you look across the screens at the top, or you choose something like Speaker View, I can see now a screen of 25 people, and then another screen of 25 people, and then another screen of 25 people, and then another screen of, yeah, there's nearly 100 people in the room. You're very welcome to anytime share your screen so we can see your face, but you don't have to. You're very welcome to contribute via the chat box or by just on microphone. And I'm just to start off with, to get a flavour of that, I just want to sort of have a little sort of trip around the country, and either in the chat box using the chat feature, or just by waving your hand. So if you go into the participants icon, so on the bottom bar, you'll find things like video, microphone, chat box, but also a participants icon. If you click on there, you'll see there is a list of all the names, and there's a few icons, and the really useful one there is the raise hand icon. So I'm just going to try something because I think we've got a really good representation from around Australia. So I'm going to take a little trip around Australia, starting with where I am in Queensland, and ask. Raise a hand or say hello in the chat box if there's one. Ray Martin, good day from Townsville. Just raise your hand or say hello. Anthony and Brendan and Deb Ray. And people raise their hand on the screen as well. Hi there. Hi, Anthony. Anthony, where are you from, sir? You want to say hello?
Is that me, Glenn?
Yes.
Am I the Anthony? Yeah, I didn't know if there's any other Anthonys in the.
Yeah.
I'm from Toowoomba. I'm actually in Highfields at the moment, just outside Toowoomba. So it's a bit chilly today.
So you're Anthony Tomnet, of course.
Yes. Sorry, Glenn. Yeah.
No, that's okay. I've met you before online, so you know I'm sorry I didn't recognise which Anthony you were.
That's all right.
Yeah, the Older Men's Network in.
Yes.
Yeah, great. So I'm getting a few messages here from different people. Brisbane, Francis, Toowoomba, we've got Foggy Ballarat, apparently. Oh, that's Mick. Yeah, mid coast of New. So how about I'm going to move down the coast. So Melinda Lightfoot, do you want to say hello, Melinda? You're on the mid coast, New South Wales. You can unmute yourself and say hello.
Hello, everybody.
Hi, Linda, Melinda. So you're in the mid coast.
Yeah, we're just establishing a Great Lakes Suicide Prevention Network. So this is kind of interesting due to the high rates of male deaths.
Yes. Right. Well, thanks for being here, Melinda. Really appreciate that, and hello Hello to everyone in New South Wales. I've just seen a Sue Johannesson from Sydney's Northern Beaches. I used to live in what used to be called Harbord, Freshwater. Where are you, Sue Johannesson?
Hi there, everyone. I'm actually dialing in from Manly.
Manly.
Which is not very sunny today, Glenn. You'll be very happy to hear. It's raining and it's cold.
Yeah. Oh, look, it's been...
It's been what?
Oh, Glenn, have you frozen? It is cold.
I know that COVID-19 has been a terrible... Yeah, but it's been... I think we've been very fortunate doing the lockdown in Australia. And I feel very, very fortunate doing lockdown in central Queensland. So it's been delightful for me. Very peaceful here. Sunny Geelong. So we're going down to Victoria now. Thanks for being here, Sue. We've got Bron in sunny Geelong. So we've got Geelong is sunny and Ballarat is foggy. Do you want to say hello, Bron? Just don't click your microphone if you want to say hello. That's okay. Silent in Geelong as well. Who's in Victoria? I'm going to say Tony McManus. I can see you, sir.
Yeah, it's a bit frosty in Bacchus Marsh this morning, young man.
Yeah, good to see you, Tony. Still. So we're moving across to South Australia. Who's? Oh no, should we pop over the sea to Tassie? Is anyone here from Tassie? I know we've got some Tasmanian folk later in the day. Anyone want to shout out? I know we've got a couple of guys from Launceston City Council and Jonathan from Hobart coming later. Not sure we're going to at the moment. Right, okay. South Australia. Someone from the country South Australia PHN or something like that. Who wants to say hello on behalf of South Australia? I've got a... No, okay. WA. I know Jacki's here from WA, but she's speaking. Anyone else here from Western Australia? Oh, Bron's talking, but Bron was saying she was talking, but we couldn't hear her. Okay. So, hi, Bron. And then to the Northern Territory. I know we've got Kim Mulholland coming from the Northern Territory later. Anyone here? Yeah, it's a bit early in the Northern Territory, maybe in WA. Anyone here yet? Hi, Glenn. Greetings from Northmead, New South Wales. Men's Community Shared. Hello there. And anyone from the ACT? Pop a message in. Okay, well, we've got a good spread from around the country. Hi, that's Greg from Newcastle. Hi, Greg. So thanks all for being here. And do participate and contribute as much as you want to. We've got 4 sessions for you, well, 5 actually, because we've got a lunchtime lecture. So there's 5 sessions now today. You can go and have a look on the program just to make sure you know what we've got coming. We've tried to give a kind of a narrative shape to it. Something we're very aware of is that obviously PHNs in recent years have been doing loads of suicide prevention work. And I think the nature of PHNs is often from the outside that feels quite unseen. It may not be unseen in your local communities, but it can be difficult looking at PHNs from the outside to understand what they are and what they're doing. And yet I'm very aware that there's been a lot of really interesting work specifically targeting men. And a lot of time suicide prevention hasn't necessarily specifically targeted men. And yet what we've noticed in the recent years with the trial sites and various commissioning that primary health networks have done is there's been lots of new projects bubbling up that are targeting men. So today is an opportunity to come together and talk about what's going on and see what we can learn from each other. We're starting the day with a session that just looks at different ways of engaging with men, which we'll come to in a minute. We've got a few organisations that have actually been commissioned by PHNs to talk about what they've been doing and maybe what their experiences are from the other side of the fence. Of course, because they're commissioned, they're going to say you're all wonderful to work with, but it might be interesting to hear some of the challenges and the learnings from that, of course. At lunchtime, we've got someone coming from the Black Dog Institute who's going to give us an update on the lifespan model and some of the plans there to how the evaluation's going, and plans to look at assessing the impact and if it differs between men and women of that work, which would be very interesting to see. I'm sure most of you are familiar with the lifespan model, but it'll be very good to get an update of how that project is progressing. And then after 2 o'clock, we have a session which is focusing on some just best practice examples of work targeting different communities of men, some work on Aboriginal and Torres Strait Islander communities, some work with LGBTI communities, some work with veterans, and some work from rural areas too. We've left the final session open, and we'll really make that your session, and we have no set plan there. We'll make sure we use that session for you to get everything you needed to get out of the day. So that's all I'm going to say about the whole event. Let me just be clear who we are, just in case you don't know. So the Australian Men's Health Forum is a peak body, and we represent individuals and organisations who are working to improve the lives and the health of men and boys. So we're very focused on the social factors that shape men and boys' lives. Then we're also connected to people working from a more medical and clinical approach, though our history comes very much from that social community space, plus a strong affiliation with academics who are specialised in men's health, which there aren't many, but we're a part of a global network of organisations that are working, focusing on men's health. And we've been around in different formats for around 25 years. We trace our history back to the first National Men's Health Gathering in 1995 in Melbourne. And for most of our history, the Australian Men's Health Forum was a voluntary organisation run by passionate individuals. It's still run by passionate individuals, but now some of us get a bit of a wage. So about 3 years ago, one of our early successes was successfully lobbying for Australia to have a men's health policy. And we are one of the 3 or 4 countries in the world that has a policy. We don't realize that when we live here, but if you've traveled around the world looking at the health landscape, you'll discover that it's unusual to have a men's health policy. And more recently, we advocated for that to be revived and refreshed. And so we now have the 2020 to 2030 National Men's Health Strategy. And as part of the process of that being revived, we were one of 3 or 4 men's health organizations that received some funding from the Department of Health federally. So we are funded by the Department of Health, and we have a small team and a large network of supporters and members that we draw upon. And we attempt to cover every aspect of health from cradle to grave. Lots of different people working with lots of different populations. Like I said, mostly in the sort of social determinant space, but also with a connection to the health space. And so for me, today is partly about providing a space for primary health networks together, but I hope here today we'll also find that we've got some people from the men's health space or the broader suicide prevention space. What I'm really keen to do is provide connections and overlaps between the men's health sector and the suicide prevention sector, and in this case, the primary health network sector. So that's all for me. I'm going to move on to our first panel of the day. And how the panels will generally work is we've asked there's 4 speakers on each panel, and we've asked each speaker to speak for up to about 10 minutes on a particular area of their knowledge, underneath a broad theme, and then we'll provide an opportunity to open that out then to questions. You can start asking your questions straight away in your comments, and myself and Mick, the producer, will keep an eye on those. But ask them in the comment box, and then we'll try and synthesize those into a bit of a broader discussion, which really encourage you to take part in, really encourage you to share your experiences, as well as asking questions of the panel, because I'm sure there's loads of experience in the room. And the first panel, to remind us to prepare our speakers, the order of speakers will be Michael first, Rachel, then Chris, and then Jacki. And I'm going to come to Michael in a moment. Just want to check that I did see Michael's name. Are you in the room, Michael?
Yes, I am, Glenn.
Wonderful. Let me introduce you, Michael, and then I'll hand over the microphone to you. So Michael Struth is the Senior Manager of Mental Health at the Western Victoria Primary Health Network. never met Michael in the flesh, but when I first reached out about hosting this event, we ended up having an hour-long Zoom conversation, and it was so rich with knowledge and information. I wish we'd recorded it, and I'm hoping that Michael can condense that hour of wisdom into 10 minutes. And as a man coming from a clinical perspective, but a man who's like worked with suicidal men, I thought it'd be really good to start this conversation with that perspective of engaging with men who are suicidal on a one-to-one basis, and get Michael's experience and thoughts on that. Michael, it's over to you.
Thank you very much, Glenn, and thanks for the introduction. I'd like to acknowledge the Aboriginal and Torres Strait Islanders and the land on which we meet today, their elders past and present, and for any Aboriginal person that may be present here today. I sit here on the Gunditjmara country and extend my acknowledgement to the countries across the network that we meet on today, and thank them in respect for our ability to be able to meet across these nations today. Look, it was a really interesting conversation that I had with Glenn, and I've actually had a slight change in role. I'm the senior clinical lead of mental health and alcohol and other drug services. A reasonably recent restructure in our PHN, with the acknowledgement that we spend a lot of time with our heads down trying to work out and towards designing and contracting and procuring services, but we focused on a greater emphasis around the system of care in the way that it integrates, coordinates, and enables access for people within our communities in a way that resonates with local communities. So in thinking about that today, I've thought about it quite a number of challenges that we front or confront as primary health network. But my background is not all in a primary health network. I've been here, this is into my 5th year now, but I have a long, over 30-year career as a clinical professional, senior manager, change agent, and I guess a system integrator of psychiatry and mental health services, both through the public sector, through my own private businesses over the years, with the National Office of Headspace, and now with the Primary Health Network. So I've got a range of different perspectives, and I think the thing I really wanted to touch on today was not necessarily about the services that are being commissioned, because we do have suicide prevention trials in Ballarat, and we also have commissioned a trial in the Great South Coast, which the major regional centre there is Warrnambool, but that's across 5 LGAs, local government areas. And in both those spaces, men between the age of 35 and 54 are the group of people that end their life through suicide in the highest numbers. And that doesn't distract from other people whom have lost their lives, but it does represent a really significant challenge about what all of that means around men seeking help, men accessing service that resonate with them and that they can engage in a meaningful way that acknowledges, validates, and helps them understand what they can do in their situation for that to be more constructive in their lives and to be more fulfilling in their life. And it reminded me, talking to Glenn, about a number of examples that I've come across, which I'll touch on in a minute. But within those trials and unpacking both the information available in Ballarat and also in the Great South Coast, there have been particular activities or projects that have been established around better understanding men, working through an awareness about how might they reflect on what's happening for them, how does that relate to their mental health and well-being, how do those people, how do we as a community recognise, inquire, engage and respond to people who are not who are actually not doing very well in their space, whether that be through the experience of an onset of illness as it relates to multiple and complex stresses, as it relates to life transitions throughout our life stages, whether it relates to conflict and relationship breakdown, loss of family, employment or loss of employment, as it relates to our sense of connection and interaction with our community and people within our community. And so one of those projects that's been developed, which is currently underway, is that we look at the system, and primarily the general practice GPs are often part of often they are the cornerstone of our primary health system. And yet we fund their fee-for-service, Medicare-related funded services, which are time relevant and often a broad screening and short interaction. Even with the long sessions of a GP, it doesn't usually get to the point that we would, generally speaking, spend with anybody to fully understand and comprehend whether this person may be experiencing an emerging illness, whether they have multiple complex stresses that relate to their psychology, their emotional functioning, the risk of suicide, and what are the factors that relate to all of that. So, number one, a challenge is about time. It's also about method and manner in which we work with each other and we relate to each other. My thinking was, I've just got a note. Hi, Mick. Link didn't work for me on both Chrome or internet. Someone's written that in. Can everyone else hear me? Yep. So, what we've commissioned is an activity with general practitioners about trying to understand not how to assess somebody that might be at risk of suicide or design a treatment plan. What is the level of confidence, skill, and proficiency in a method of appreciative inquiry that seeks to engage people in self-determined change, that sits with someone around using a range of asking questions and envisioning the future about what this means for this person at this time. It's actually brought rise, this methodology and this way of thinking was brought rise to the positive organisational studies and the strength-based models and movement that have been really developed across the United States for a start, but have really started to embed in what we strive to achieve in mental health service delivery in Australia. It's about the idea about envisioning the future is in order to foster positive relationships and to build on the present potential of a person and or a situation. And so that idea that we sit alongside and we are a resource to and can offer a range of or access to a range of things that may be of assistance means that we first and foremost must get through that initial engagement, that initial introduction. And when I moved from working in my own private business, I had over 70 professionals working across a whole range of Aboriginal and Torres Strait Island health conditions, Aboriginal community controlled health organisations, general practices, right across this country. The thing that really struck me in this space, and when I returned back to the public mental health system, was that the way in which men express themselves when they're seeking help is often not about, I need some help, can you please help me, in a non-emotive way. Now, I'm not meaning to be stereotypical there, because many men do. And there can be many kinds of presentations that, relate to someone being tearful, being angry, being defensive, being accusatory, being antagonistic, being threatening, or being reflective. But when it actually escalates, when when there are multiple stresses and compounding losses, there's often a sense of disconnect, detachment that is expressed through frustration, emotion, desperation, sense of injustice, and that often that's the presentation that somebody else sees. And that the method of actually being able to engage with people is first and foremost acknowledging who they are as a person, being able to validate and connect with the emotional expression and what lies behind that, and taking the time to get beyond that to be able to see the manifestation of, is this likely to be a predisposed illness like depression in amongst all of this horrible set of circumstances? Or is it a situation that someone's not managing particularly well and not coping with? And how do we actually engage in a way and enable access to a range of things that might be of some assistance to this person to better regulate themselves, to problem solve, to engage others, to assist them in considering options to be able to make decisions for themselves. And so in our systemic design, one of the considerations that we're making as a PHN is the workforce development that is the first response from a health care level in a way that resonates with the person that's either not even knowing that they're seeking help. They might be just going to a social service or to a GP because they need to, because there's a legal issue or there's some other matter, but in a way that actually helps them reflect, and through an appreciative way that is respectful, guide them to a place where they can say, okay, that makes sense to me and that resonates with me. And I didn't understand this was an illness that was emerging, or, okay, I'm glad that it's not an illness, but it doesn't feel any better. So what can I do about it? Because I'm at risk of losing my children, my relationship, my family don't want to see me anymore. My community, I've been taken from my community because I lost control and I got aggressive or violent. None of which we condone, but in the very first instance, it makes sense to be able to understand and not to make a judgment, but to be unconditional and enable people to take control, but to develop the skill sets to do that and move forward. And so that's a real question that we've got. And I think that that's, from my way of thinking, that the first time the zero tolerance to violence policy came out in Victoria and Australia, my immediate thinking was, okay, that's a useful idea, because I don't think anyone has a right to behave violently that places anybody else at risk. But my real dilemma was it's a thin end of a wedge to intolerance, and not to have understanding that resonates with someone, not to validate that there is an emotion that's driving this and probably a reason behind that, and not to get to that next level. So, and what I experienced was those people with very serious mental illnesses who, combined with their personality constructs and the way and their behavioural patterns, who would then resent being who didn't recognise the need for treatment and would resent and resist treatment that was offered and couldn't see any benefit from that, would then either be, it would involve police immediately, it would involve restrictive containment techniques to manage the risk. And so in that sense of duty of care, the health system, through all of its medico-legal frameworks, moves towards containing the risk, which actually suffocates the experience of the person, moving them further away from the help that they need. And a health professional that is frightened or fearful of someone in terms of their own safety cannot avail themselves to be of assistance to a person that is abusive, aggressive, accusatory and antagonistic in the same way as they can if they engage with them through a validation and a sense of understanding. Okay, Mick. So these are real challenges for us, and I think that they're well worth following up in terms of the design and the capabilities that we build and promote in our broader system of care in the primary care space.
Thanks, Mick. That's really insightful, and you pose a really important and a really interesting challenge for us. And I think something that really resonates with, more broadly in my experience of the work that I see across the men's health sector more broadly, that, you know, men will often show up in the system and be seen as a problem first or a risk first, rather than show up in a space where people are asking, what is their problem and how can we help them? And that can be true of, we've got member organizations who, for example, work with men who are sexually abused as children. Yeah. And they often don't show up in the first instance saying, I was sexually abused as a child, I need help. They may show up in an alcohol service or in a homelessness service or in the justice system, often angry, externalizing and so on. Yeah. Similar with working with, we have organizations that work with separated dads, very similar thing. They can show up really angry and cross, and within 5 minutes, if they're in a space that's actually focused on dealing with the situational stresses of separation and around people who understand that experience, that sort of anger and frustration dissipates very quickly. Yeah. And often the anger and frustration seems to be an expression of not being heard and not getting what it is they need, which is someone to actually help them with the situation they're dealing with. And then beyond that, often we can then get into conversations about the mental health care and all the rest of it. So the anger management or whatever it is that is also necessary. So it's whilst not coming from a clinical background, certainly in terms of the organisations that we work with, working with men, like from a peer support perspective, what you're talking about really resonates with that broader experience in the men's health space. So. Thanks for what you've brought to the conversation. I hope you're able to. I know you're a super busy man. But
that's that time of year. But I'll just make a quick response to that, and just sure. this idea of clinical. In my mind, the role of the clinical component of services with people is about whether or not there is an illness that could benefit from treatment. But the rest of the way that the person operates and functions, because that will guide a particular need for medication or surgery or whatever the area of health is. But the rest of it around our psychology, our emotions, our skill sets, our communication, our ability to understand and apply is just human. It's universal human needs and responses. So in the absence of the illness side of it, then we tend to actually respond to very similar things if we feel understood and validated in that context. So it's the only point that I'd make. But I certainly will stick around for a while, Glenn, because I think it's a really important summit and very pleased. And thank you for inviting me along.
Great, thanks, Mick. And I hope we've got some. Drop questions that you have to Mick in the chat box, but also we'll have an open discussion towards the end of the other talks, where you're very welcome to contribute and also ask questions directly to Mick. So just a note to thank you so much. Just a note to our speakers. Try and keep an eye on your chat box, because about 2 minutes out, I'll drop you a little message, and then I'll jump in about a minute out from your time and start interjecting. I appreciate all of you. We'll be able to deliver an hour's presentation on what you know, and I'm really committed to us giving all the speakers a good crack at it, and also giving the attendees a chance to ask some questions. So with no further ado, I'll move on to Rachel. So Rachel Hughes is the Senior Programme Officer for Suicide Prevention Eastern Melbourne, PHN. And I think I often say she was like, I say to Rachel, you were my first PHN, because Rachel was the first person working with a PHN around suicide prevention that I engaged with maybe about 3 years ago, and was the first person who showed me inside the world of the PHN, and actually did some work with her down in East Melbourne, which I'll reference briefly in the second session. But I'll let her introduce herself. Beyond that, really delighted that she's here. Looking forward to what she has to share about the work that's been going on down in East Melbourne. Rachel.
Thanks, Glenn. So I think that I will, here we go, I'll see myself here. So I'm going to share my screen. I have a different type of presentation to Michael, so that's always a good thing to have different styles and different types of information from different PHNs. So I'm going to share my screen, host disabled participant. Mick, are you able to, not Michael Struth, the producer. Okay, I couldn't share my screen. I've got such a good PowerPoint. I really want to show it. Is it possible to, I should have really sent it to you beforehand.
Yeah, I'm just looking for you in the list. Then I have.
Rachel Hughes.
Yeah, I can't. I'm not seeing enough alphabetical order. Sorry about this.
That's all right. While we've got that happening with the producer, I'll just start with the acknowledgement of country. So we would like to acknowledge the traditional owners of the land that we all each meet on today. I currently sit on the Wurundjeri land of the Kulin Nation, so I'd like to pay my respects to their elders past, present and emerging. Also, I'd really like to acknowledge the people with lived experience and all that they bring to our work and the work that we do in the community, and very much so in this work that we've been doing with the suicide prevention trials in Eastern Melbourne PHN. The role of lived experience is very important because the reason for the trials are to help communities to prevent suicide themselves. So we definitely have to embrace and be guided by the lived experience in community, and particularly in men's health, that I'm obviously a woman and I identify as a woman, and I needed to be guided by men to give those, I guess, those insights like Michael was talking about earlier, and that Glenn has articulated about how men might not have particularly different needs, but they may present in different ways. So we've definitely been drawn to our ways of working and being guided by men's perspectives. I feel distracted about the screen sharing. How are we going with that?
Actually, yeah, that's all good now. You should be right.
Excellent. Here we go. I'll just share that. So we don't want now can you see my screen there now with the PowerPoint there?
Yes, we can.
Yeah, right.
Yeah.
Yes.
Excellent. Good. So, I've kind of got two screens going on, so I may not look at the camera the whole time, just while I'm doing the screen on the other screen. So hard to reach, like what does that really mean? So I think that we've got to really challenge ourselves with that language, and hard to reach is a term that we do use as a PHN, but I think we actually in the suicide prevention trials didn't come from it in a perspective of hard to reach. We were looking at the men take their lives by suicide in higher amounts than women do. So we were looking at, I guess, target cohorts or more at-risk cohorts. So we knew that we wanted to engage with men because they were presenting as more at risk of suicide and taking their lives. So it was really the start point of like who's at highest risk, and also I guess they could be considered hard to reach sometimes, you know. So I think that we've got to challenge ourselves with that terminology. I think interestingly I came across a quote that really resonated with me, because sometimes the work that we've done I think has been quite expensive on some level. So some of the things that we've done, the total cost could be perceived as expensive considering how many people you might reach. And I found this quote by a person called Paul Vittles, who commented that no one is hard to reach, just more expensive to reach. It's important to put more effort and creativity in reaching these groups. And I think for me, that's definitely been the perspective, because you do sometimes have to look at as a PH and your value for dollar, but you've also got to look at what's necessary in order to reach the people that you are wanting to serve your purpose, serve. So we were really blessed to have the Victorian suicide prevention trials. So I'll talk about a little bit more about that in a while. But basically where we're coming from is that this policy background and this framework, really if we look at what that the underpinnings of that is, it's learning what works best and helping the local communities. So I think for us as a PHN and as a, Victoria, they're all, Michael was talking earlier that the trials are in Ballarat as well, so they're across the 6 Victorian PHNs. It gave us some safe to fail kind of options, like it gave us the ability to try things out. So I think that gave us a little bit of more freedom than just that straight commissioning and service delivery modality that we generally do in the PHN. So these are the trial sites that have been going on in Victoria. So I've put a website address there because I won't go into a lot about that. Mick was mentioning the link for their website as well. So that's the DHHS website. So the State Department of Health and Human Services have co-funded the trial sites. So each PHN has funded one trial site with their Department of Health money and one trial site with their DHHS money. And we work together as a Victorian Alliance of PHNs, and we also, each coordinator in the trial site, we all attend a community of practice that is conducted by the department. And that really enables us to share our learnings, share our resources, our thinking, and there's also a statewide evaluation that happens from that. So I think what I would say to having that community of practice is that I know that some of the other PHNs have been focusing also on men's health. So with Northwest PHN, there've been, people may know about HOLT, Hope and Life Hope and Life Trades. Sorry, I feel like I should have written it down before, but it's Jeremy Forbes Holt, and he does the bacon for brekkie trade sort of breakfasts. And so Northwest PHN have been engaging with Jeremy, and as well Southeast Melbourne PHN are working with him as well. So in regards to our work, I'll just give you a quick clip here. So I really wanted to show you the vibe, as the castle would say. So that's one of the big pieces of work that we've done. We've run 3 men's health lunches, and I'll go through a bit of detail about that, and I'll try to hasten myself because I feel like time's running out. So what I want to sort of first preface it with is that we've been working from a model of suicide prevention based on Rory O'Connor's work of the motivational to volition model, and we've placed a wellbeing element in there as well. So we really see this work as that pre-motivational phase, and helping people that may be at risk to target at the strategies towards them. So I really want people to understand that we're working within an evidence-based suicide prevention model as well. So because these things can be perceived as fun or soft sort of approach, but it's about how do you engage with the target cohort or the at-risk cohort, and that's where we have commenced that work. So the types of work that we have been doing in Eastern Melbourne PHN in those trial sites. So we've got our full catchment, but we've got our trial sites as well. So we've done 3 men's health lunches. The one for this year was unfortunately cancelled because of COVID-19. And I actually, in reflection, feel like a lot of these activities that we've done are very going to be very challenging to do in the new environment. Having said that, we've been working with Sons of the West with the Western Bulldogs to do a Sons of the West in the North, we call it, because of our trial site being in the North. And we've been working with the local community to put and pilot that program into Whittlesea, and we're crafting that with Western Bulldogs to do that in a safe, COVID-safe way. So having small groups and connection points through online and some small group face-to-face. So we've also, with when I first met Glenn, I was working with him to do the Stop Male Suicide training. So we ran a number of training sessions, and that was fantastic to give us a groundwork of what we needed to consider, but also helping clinicians and community members and leaders in the community to think about male suicide as needing some slightly different focal points from the broader suicide prevention frameworks that we use. We also engage with Sports and Life Training, which is a local organisation, and it was based in the trial site. So I know Northwest PHN have been interested in getting SALT out to work in their sporting clubs out that way. So yeah, check them out as well. So I guess in the men's health lunch, I put this photo here just to show the Wayne Schwash was one of our speakers. So some of the things that we considered was, you know, how to engage the men based on what would be meaningful, and having a peer or a leader that would resonate and be able to bring in the information, because there was synchronicity and you know, that person was revered, I guess, as well. So we used quite a number of quite well-known sporting people. And we also used that with the local business that we were engaging with in the trial site. So we were able to do a men's health lunch and target those business communities. And what we were really happy with as well is that it was really popular. It was a really great vibe. We had men's health information and that suicide prevention through those key speakers. We had a comedian that kind of did the buffering of the information and they bring people into the fun and the sharing, because I think we were guided by this as well. Suicide prevention is a serious topic, but we don't have to be, and it's sad when people die by suicide, and I would never diminish that part, but we wanted to make sure that we were engaging people, because one of the key messages that we were doing was it's about looking after yourself, but also looking after your mate, and not to, that you need to reach out and I guess, like, how do we make that comfortable for people? And we were guided by the men that we were consulting with that this would be an appropriate methodology or appropriate things to consider. Glenn, how long have I got? I might just
take another minute.
Yep. So we also did some fun activities, and you can see there that they weren't sort of, they were engaging and brought audience participation in as well. We also thought about our collateral, so what kind of information would men take on, and being guided once again by people's opinions in those governance groups that we were working with. So we did keep cups, and we sort of packaged the information of support lines into more appropriate ways of seeing the information, rather than just a brochure that you might see at a community health centre. So yeah, once again, back to Sons of the North, Sons of the West in the North, that I think what was really important with this is by doing suicide prevention this way, we were being able to capture, this was done in Whittlesea, we were able to capture men that were hard to reach. And the reasons why is because they may have been from a cultural and linguistic diverse background, they may have been older and not participating in community activities, Aboriginal and Torres Strait Islander. And we had just such fantastic results from that initial pilot. And what we understood from that is that it may not be perceived as suicide prevention in a traditional approach, or how we might perceive it as a PHN or a service delivery approach, but it was about engaging men to be part of the health information and health promotion, and suicide prevention was a component of that. So once again, we weren't sort of delivering it like face kind of in your face messaging. It was built into a whole suite of men's health, and that was, I guess, a bit more palatable for people, or a bit more engaging for people to understand their the range of health issues that men may face. Having said that, the suicide prevention elements were that fantastic connection to community that we know helps prevent suicide. There was not a huge focus on mental health as suicide prevention, because we know that they're not always together, but we did see an increase in health promoting behaviours and being able to talk about emotions and feelings, and also that gender equity. So we had some sessions on respectful relationships as well. So really a snapshot of 4 years work, and obviously it sits within a breadth of work that we also do in our catchment and in our trial site. So I guess one of the challenges, or two of the challenges that I would mention, was some of those things. The Sons of the West is a sort more of a service delivery element to that, but with the men's health lunches, I think what was challenging for us was how to evaluate that, so how to get that feedback from men. And I would say we didn't do that all that well, because we did consider how we would grab information and feedback, and we tried our best, but it was a difficult thing to do. And having said that, we've got some great outcomes based on the fact that the local council there in Maroondah was going to take that on in a sustainability way of part of their suite of services or suite of programming that they do with their Biz Week activities. And the other challenge that I was thinking about, which I will just, I know I'm running out of time. So,
all right, Rachel.
What was I also thinking about that, just check my notes. There was a really good challenge that I was.
Okay, if you can't get it, you can post it or say it later.
Yeah.
Okay.
Yeah. So anyway, so that's the end of my formal presentation, and really happy to have a chat about the work in a more informal way.
That's excellent. Thanks, thanks, Rachel. Good to see all the different activities. Well, some of the different activities you've been up to, and I think. And the thing I want to really acknowledge was I haven't seen the whole project, but I sort of engaged with you very early on, and the amount of time you took to sort of really think through and try and get to know the issue and understand the issue, rather than just sort of jumping in with the solution. And I know the sort of the depth and length of conversations that you had with me, and no doubt you had those conversations with many people. And so there was a really good learning note from me there, was not to assume you have the answers, but actually to start exploring and consulting and engaging. And I guess that's one of those things that when PHNs do stuff well, that's what's special about PHNs, is that relationship and that partnership and that co-creation piece with the communities they serve.
Definitely. And I think what I would say to that too is that foundational, those policy, so PHNs, really the work is about policy from government, translating that, implementing that into service delivery. So designing the service model and the service solutions, and then implementing that. And the policy guides us and directs us that has to be the foundational piece, is that co-creation and understanding the issue, getting the data, so that we were guided by those target populations, so to speak. We're definitely guided by data that we had from the department and our own needs analysis. So I think that they're not plucked out of thin air why we designed it this specific way. Yeah.
Got it. Yeah, thank you, Rachel. And that sort of brings us nicely on to Chris Jones, because thank you very much. We'll get you involved in the chat later on. Any questions to Rachel, you can start popping them in the chat box as well. Don't wait till later. Start now. So Chris Jones from southwestern Sydney, similar to Rachel, I came across southwestern Sydney's work when I read about some really impressive sounding sort of co-creation forums where they'd got loads of men in their area together to sort of talk about what would suicide prevention look like. And I thought, well, that'd be interesting for Chris to talk about. So I sent Chris an email, and then what came back was a whole list of other stuff I wasn't aware of. And I went, well, we definitely need to get Chris, and I'm not sure how he's going to get all that into 10 minutes. So I'll stop talking and allow him as much time as possible. I'm going to hand over to Chris Jones, who is the mental health manager at Southwestern Sydney PHN. Thanks for being here, Chris.
Thanks, thanks, Glenn, and hi everyone. And thanks to Glenn for the invite as well. It's an absolute privilege to join everyone today to talk about men's mental health and suicide prevention, and just some of the approaches that Southwestern Sydney have begun to take over the last 4 years. So similar to what Rachel was saying before, our PHN has been on a real journey with men's health. We're fortunate to have some super passionate people in our region that are just really helping us to build some positive momentum. So I'll get to that in a second. So hopefully, Mick, I'm able to share my screen as well. I'll just give that a go. So I think you just need to enable me there, Mick, similar way that you did Rachel previously. Yeah, that looks like that's going to work now. Okay, so can everyone see my PowerPoint okay? Fantastic. So just to start off with, I wanted to join my fellow presenters and Glenn just in acknowledging the traditional owners of the land in which we are all meeting in our respective meeting places, and pay respects to elders past, present and emerging. And also anyone joining us with a lived experience of mental illness, their family, friends and carers. So like I said, this is just a snapshot of some of the things that we've started to do in the suicide prevention space and the wider mental health space in our region in regards to reaching men. So I'm going to move through pretty quickly because like Glenn said, I've got a reasonable amount to get through. So if there's questions at the end, happy to take those. So the first one that I wanted to focus on is just understanding in a general way how men are currently accessing some of our clinical services. So like many PHNs, a big part of what we do is in commissioning mental health approaches around our clinical supports that we design and make available in our region. So on average, men had averaged 5.6 hours per episode of care, and that was compared with an average of 6 hours for women. And in the period of the 2018 period to 2019, so that 12-month period, just over 40% of referrals to mental health episodes were men, compared to 60% for women. So it got us to look at two key elements that if we thought we were going to develop some responses in conjunction with men, we wanted to look at. So they were looking at warning signs to help men better identify some of the risks in themselves and their family, friends and loved ones. And with that, the tools and pathways that are potentially needed to become more proactive in help seeking. So the whole proactive, has become our real catch cry within our region over the last 18 months, helping men to become proactive in seeking out those supports. So along with that, we wanted to challenge some real key myths and assumptions. And these were our top three. So the first one was that men don't want to seek help or talk about their feelings. So I'm pretty sure that everyone online would join me in that sentiment in the men that we work with. The next one is all men who attempt or die by suicide have a mental illness. So we know that it's much more complex and multifaceted than that. There are a whole lot of other underlying issues at play for men, and it's not always as simple as a diagnosis of a mental health problem. And men, by their nature, aren't proactive when it comes to mental health. So as Michael and Rachel, really well pointed out before, it's often men present in a different way that we need to come to grips with, and that's the whole reason why we're having discussions today about different ways of reaching men. So the next one was just specifically in regards to how men access our clinical suicide prevention program. So we've got a particular stream of our program that provides rapid support to people that currently have suicidal ideation. And again, it was really interesting that the split here was almost the same as the one that I gave you for overall psychological therapies in the beginning. So just over 60% for female and 40% for men. And in regards to, you know, the rates of which men are dying by suicide, so that's 6 in 8 nationally. We know that those statistics probably aren't as indicative of the need that actually is out there. Breaking it down by a regional rate in regards to presentation across the 7 parts of our region. So the pink bars representing female deaths by suicide and the blue being men. So we can see that that's very much in line with the 6 in 8 suicides that we see nationally translates within our region. And there's pockets of our region, particularly our semi-rural pockets of the region, Wallandilly, the Highlands and the Southern Highlands area, and also Campbelltown being the highest in regards to how those rates translate across the region. So some of the approaches that we moved on in regards to our partners. So we fund Lifeline MacArthur in our region to run our regional approach to suicide prevention. They do a whole host of great things, including extensive education and training. So they've trained, I think at this stage, over 4,000 people over the last couple of years in things like mental health first aid, assist living works, mental health first aid for the suicidal person, and a range of others. They also do great things like means restriction, bereavement support, aftercare. But another thing that they've instituted in the last couple of years is the men's long lunch format, which was great to see that in Rachel's previous presentation, you know, that we're doing similar things in our region. These lunches have been absolutely successful. They've had several hundred men join the lunches over the last couple of years. They come along and listen to some key speakers, as well as being able to have a chat with others in the region. And the thing that I love about these lunches is that a lot of the local businesses will pay and donate for their men to come along and join in the cause and meet other men in the area. And the conversations that take place about what's happening in the workplace, what's happening with you know, guys and their friendship groups as a result, is helped to build a platform of probably what I'll speak to you next of what we've been able to take that to in the region. So a big fan of the long lunches. The next one is a program that I've just been super proud to be involved in. I know that I've got Emma George on the line from Western Sydney Uni today. So hello, Emma. So Emma and her team at Western Sydney Uni have project-led design and coordinated a program in conjunction with the Canterbury Bankstown Bulldogs NRL club. So I think there are 4 programs into it at the moment over the last couple of years. And Active Breed is a 12-week program for men aged 35 to 64. And it's got a really big focus on helping the male participants to improve their physical and mental health, lose weight, and also learn about mental health through a series of weekly education and exercise sessions. That's all conducted over at the Bulldogs training ground at Belmore, which is the spiritual home of the Bulldogs, which is just an absolute thrill for all of the guys that participate. They have some of the players come in and provide some encouragement, so you can see Josh Jackson and Terry Lamb part of the photo there. And the mental health sessions that I was fortunate enough to deliver cover education, not just around basic mental health literacy, but also around service engagement in the local area, and some real conversations around breaking down stigma and challenging some of the myths around how men can become more proactive in addressing their own mental health and that of their friends and loved ones. So topics such as stress, anxiety, depression, and help seeking. And just some inspiring quotes over the next couple of slides. So these are quotes from the participants. So it's not just my journey in regards to mental health, but I know it's many people's. Oh, sorry, let's get back there. It's not just my journey in regards to mental health, but I know it's many people's. I just want to be a good friend out there for anyone and just be able to identify and be able to say, hey, people do care about you and you can get help. So I think it was an unexpected outcome that I didn't anticipate. It's from Ahmed. And then the next one, I'd say the mental health side of things has resonated probably with my wife a bit more because of what we're going through with the whole postnatal depression type thing. I think she's more willing to talk to me because I understand a bit more, and I'm willing to actually not just dismiss it and go, it's just motherhood, get over it. It's actually a real thing. I think I'm more approachable, and that makes a big difference to her. So they're just amazing quotes that have obviously not just resonated with participants, but they've taken it back to family members. And then the next one's in regards to the female partners of active breed participants who say he's taken it back to the workplace as well, you know, about the mental health side of it and things like that. Because being in the banking industry, it's very role oriented and it's target set and things like that. So it's a very stressful environment. He's taken it back to them as well, which is really good. So he's been mindful of that. And the second one, the mental health stuff, he's found very interesting. I think probably being in the fire brigading, having some of those stressful situations, that's been very good for him to understand some of the things he can do for that. So again, people have taken it back to their workplaces as well, and things that they learn in active breed continue to resonate in their communities far beyond the initial training, which is fantastic. The next one I wanted to feature on is a project that we're happy to support that has been undertaken by our local health district. So our tertiary services, their health promotion team, they've got a program that they run called Talking Men's Health. And it's a resilience and help seeing pilot project. And it's all around men's storytelling, a narrative approach to how men show resilience in their communities, featuring some stories around men dealing with chronic health conditions, aging, loss and grief, relationship breakdown, addiction, unemployment, and across the board lived experience of mental distress. So some of the actions have resulted in help seeking, self-agency, a range of men's groups, recovery, relationships, community connection, self-talk, hope, mateship, self-care and lifestyle changes. And it's led to those stories being featured in local print media, radio. It's led to a lot of the guys that participated sharing their stories at local networks, informing PHN panels, a whole range of different things. So in regards to Matthew's story here, you can see that Matthew lived with PTSD after being shot from a distance when he was boarding health supervisor. The result from that was panic attacks, depression, divorce and unemployment. And he used a range of supports for recovery and now leads a local men's support and recovery group in the region. And just also showing us some of his self-help approaches through the sport below. So the success of this project is that, like I said, it was featured in the print media, radio and a range of networks. It's part of a research project by Western Sydney Uni through the Men's Health Information Resource Centre. It's led to mentoring opportunities and connections to other projects for participants. And the story resources are in development for broad community and community sector use. And we're supporting the LHD in making sure that those stories get out there. So a range of those things have led us to more recently where we're currently at the moment into a real regional approach for men's suicide prevention. So like Glenn was saying before, we were fortunate enough to host 2 co-design sessions to design proactive approaches for men's suicide prevention in early May of this year. And we held those in Campbelltown and Mittagong in those 2 different parts of our region. So we attracted...
Chris, just 1 minute now.
Yep, I'll just wrap up. Yep. So we attracted 95 participants to those co-design sessions. It's probably one of the highest co-design turnouts that we've had to date for our 4 years of doing mental health work within the PHN. So all participants worked on a design brief to talk about potential projects that could improve proactive approaches to men's suicide prevention. We had featured presentations from organisations outside of the area as well to help generate enthusiasm and create a dialogue around our projects. And the co-design produced 5 key theme areas. So those are mentoring, education and capability building, marketing, support groups, and community connections. So we've fed those into a grants approach that we're currently reviewing at the moment. So we're actually reviewing that this week, which is exciting. And once funded, those projects will help equip men to identify suicide risk equip men to utilise tools and navigate life's hurdles, hopefully reduce social isolation, and provide clarity regarding supports and services available. And those approaches will hopefully be available across the region. We're also looking to evaluate all of those approaches. So we want to make sure that we've got an evaluation that can measure effectiveness of how the grants actually assist men to become more proactive, whether what we funded actually matched up with what we heard in co-design. So we want to make sure that it's got a through line to what people were telling us. And most importantly, did we listen and act to what we were told? And just wrapping up, some of the other approaches that are key to note, we've got an app that we run in the region that again focuses on stories of hope and resilience. That's our only human app. Many of the stories on there are from local men in the region. Numerous workshops and roundtables that have been able to feature stories of hope and resilience of men in the region. Additional video and multimedia content, which is a growing library that features men's stories, and a successful consumer and carer advisory group, which includes men from multiple backgrounds, experiences, and opinions and lived experience of mental illness. And that's it. Thank you.
Thanks, Chris. So rich, you managed to pack an awful lot of information into 10 minutes. I mean, two key takeaways in different groups and communities of men in thinking about this issue of male suicide, and also providing that, you know, we talk a lot, men need to talk more, but actually providing a facility, a mechanism that actually gets men's stories out there is a fantastic initiative, and one I'd love to see. One I've heard about, but not really dug into much, and one I'd love to see talked about more and spread around the country as a way of, you know, of sharing men's stories. Fantastic idea. So last but by no means least, I'm going to hand over to Jacki Ward, who I've met a couple of times over the past couple of years. And what I know about Jacki is she's super passionate and enthusiastic about getting out to rural men in WA. And she covers like such a huge area from, I guess she'll tell you, but at the very least, from something like Broome down to Albany, I think maybe. I don't know, you'll tell me, but it's Western Australia is such a huge area, Jacki. And to give you your formal introduction, like I did with everyone else, he says, buying time by speaking slowly, scrabbling for his notes. Jacki is the project coordinator of the suicide prevention trial in the Midwest. Thanks for being here, Jacki. Over to you.
Thank you, Glenn. And no, not quite that, but I will show you. Oh, if I can share my screen, please.
Should be good to go to Jacki.
Thank you. There we are. Can you see that, Glenn?
Not yet.
Oh, damnation.
Mick, I'll leave it with you.
No worries. If you just click on the share button, Jacki,
Yeah.
and then select the screen where your presentation is. Make sure it's open.
That better?
Here we go. It's getting there. There we go. Then you can go to slideshow and we're all good.
Yes. Okay.
Beautiful.
All good now. I'd also like to respectfully acknowledge the traditional owners on the land which we meet today, and where I am in Geraldton on the Midwest Coast, this is the Southern Yamaji people. So not quite Broome to Albany, but definitely Exmouth in the north. I cover about 650,000 square kilometres here in the Midwest of WA. So the Midwest region goes from Exmouth, as I said, down to Carew Shire in the south and across to Wiluna. And in this area, we've got fishermen all the way up and down the coast. especially rock lobster or crayfish, we call it, around Gelton, which is the little yellow bit, if you can see that. Scallops, prawns are caught around the Abrolhos Islands and the Shark Bay area. Around Exmouth, that's game fishing, and they also have a big tourist industry around that up in Exmouth. In Carnarvon, we've got plantations that you've probably heard of Carnarvon bananas, so that's plantations around there. We've got a lot of mining around Sandstone, Meekatharra, also Murchison, magnets, and around Gelton, like I said, we've got the crayfishing in Gelton, but also wheat and livestock farming all the way around Geraldton, Northampton, down as far as Karoo through Perenjori. So quite a little bit. In Geraldton, it's a port town. Main exports are mineral sands and grain, plus the crayfish out to China. So we've got a lot of farmers, fishers and FIFO workers around in the Midwest, men whose jobs may not allow them a great deal of control over their finances at times, with things such as the weather, the catch, or ongoing contracts in the mining industry. We all know the horrific stats for male suicide, and in the Midwest, it is just as bad, I'm afraid. So we were given a Commonwealth suicide prevention trial in 2017 by the Commonwealth, and we've just had a year's extension to June 2021. We chose to look at men, concentrate on men aged 25 to 54 when we looked at the data that was available at the time. I work closely with my state counterpart, mainly to avoid any duplication and to utilise what money we've got more efficiently. With the trial, this PHN chose to the Alliance Against Depression for our suicide prevention trial. The Alliance Against Depression has 4 pillars. One, to increase community knowledge in mental health, and we do this by providing free standard mental health first aid training for communities and question, persuade, refer or QPR sessions. We upskill health professionals around depression and suicide, and we've used a well-respected psychiatrist who's also a GP for this, and most GPs throughout the Midwest have now received training several times. We ensure that communities are aware of what's available in their community, whether it be a drive-in, drive-out service or an online service. We use media to promote help-seeking behaviour. So how are we engaging with men? Being mindful of the 4 pillars of the Alliance Against Depression, we set out to engage with men basically any way we could. One, by providing education around mental health to reduce stigma and increase help seeking, and to ensure that men knew where to go to get help. And if possible, we encourage their first port of call to be their GP. We use education, like I said. We provide question, persuade, refer training, which is a 1-hour session teaching people how to recognise the signs of suicide ideation, and also the 2-day standard mental health first aid course. We ensure that all sessions are conducted in the QPR sessions are conducted in the workplace at a time suitable for the participants. Also, especially with the 2-day mental health first aid course, we can offer the education in small portions to fit into their workday. For communities, we also have to be mindful of the time of year. We can't go into a farming community during seeding or harvest because we wouldn't get anybody there. And we've completed QPR and the standard mental health first aid in numerous shires and communities throughout the Midwest. The last standard mental health first aid we did was in Gascoyne Junction in February, just before COVID-19 lockdown stopped us going anywhere. We've also been targeting businesses around Geraldton that employ a lot of men, a high male workforce, and those that use the skills are contractors or the flying fly out workforce. In these pictures, you'll also see plenty of women. We found that if we can't get too many men to these sessions, for whatever reason, we educate the partners or their mums or sisters, and they take the message home. And in doing that, we found that the mental health message does get out there. But the main point of this education is to build capacity in the communities, because we can't be everywhere or do everything. And as you can see from the previous slide, we've got a huge area to cover. Like I said before, we take education to the workplace. We use skills and stories of blokes with lived experience to engage with other men. We've used a tradie with lived experience, which is Jeremy Forbes, whom I believe Glenn is going to have talk to everybody on Saturday, and he's from Hope Assistance Local Tradies. We've used a farmer with lived experience, and he was supported by Roses in the Ocean, to talk with farmers at field days about his journey with depression. And we've used mates in construction to conduct assist training for businesses in the building industry around Jordan. We've attended numerous community events, field days, the festivals and stuff like that, to let people know what is available in their local community, what services are available, and how they can access them. And we also promote things like Lifeline, the Men's Helpline, Kids Line. As some people may prefer the anonymity of these services, and especially in very small communities. Sometimes, as I've said before, we can't specifically target men, but educating other community members can be just as well. We've supported blokes at men's sheds, such as the Chapman Valley Men's Shed, which has refurbished an old coaster bus to be a travelling cinema for very small communities around the Midwest. And with the cinema bus too, they not only see a movie, they come together for a meal. And also it's a good way for me to be able to let that community know what's available in that community, what health services come, and also to talk around mental health too. And if anybody's interested, Shinema means men's shed and cinema. With sporting clubs, we've supported the Tomorrow Man initiative to come to the Midwest, and this has been very successful, with 11 sporting clubs throughout the region hosting an event. And of the average, 15 blokes, young and old, attended each event. We partnered with Rotary clubs to add value to their mental health education their days as well.
Okay, about a minute to wrap up if you can, Jackie.
Okay, not long. We've used a media campaign targeted at men. This was called Inside My Mind, and we used 4 people to tell their stories, and an artist put their thoughts on canvas. We had a very wide-reaching audience. We used airport terminals, static displays, and at fitness centres, hardware stores, licensed venues, anywhere basically where men would go. And we got some drink coasters printed up so that they could decide, they were sized to be put into a pocket if they wanted to take away. So what have we learned? Education's good, but it needs to fit around the workday. We need to go to them wherever the workplace is. We need to use a speaker they can relate to. We've utilised field days. We've involved the whole community, and we found that giving them something to take away to be seen later or looked at later has been good too. Unexpected consequences have been that the GPs throughout the Midwest have said to us as the PHN that their workload has increased quite markedly. And so we, as a PHN, will have to work with the GPs and other mental health services throughout the Midwest to to see how we can help support them in the future. Thank you.
Great. Thanks, Jackie. You managed to pack, even though you don't cover all the way from Broome to Albany, you still managed to pack a lot of information in about that huge area that you cover, and how you need to take into account the specific needs of those diverse communities of men, and the challenges of reaching them when they're busy at different seasons and different times. So yeah, really sort of interesting insights there that had another layer to the conversation. And I just have to say that's my, I was actually talking about that coast with one of our board members, Pete Smeagol, former CEO of Lifeline. We both agree that the Ningaloo coast there is probably one of the best coasts in the world, but we won't tell everyone about it. Let's keep it special. Yeah. Okay, thanks. So we officially finished this session in 5 minutes, and then there's officially a 15-minute buffer between this and the next session. But this is what we're going to do, because there should be no queue for the kettle. This is one of the joys of working from home, or coming into an online conference, and there's very little opportunity to network with people over the biscuit, because we're all in our separate space. So we'll officially end the session around about 11:30 to allow our speakers to go if they need to. But we'll just keep the conversation going through to the next session if you want to do that, because the room's here for us to have conversations. So I want to just firstly go back through our panel, because you've now had the chance to hear what other people have got to share, and just ask, I'm going to ask each of you if you've got anything that you want to reflect back on, any major point you missed, or anything that sort of an additional layer of thought you had when you were listening to the presentations. And if Mick Struth is still on, or Rachel, is Mick still on?
You certainly am, Glenn.
Awesome. Anything you want to sort of bounce off there from the 3 presentations you've seen?
Look, it's just a pleasure to sit back and look at what's being done in the other regions. We do get the opportunity around the primary health networks to meet up and be informed about the activities of other trials. So it was terrific about detail, but I guess one of the things that was really striking is that ideal around synergistic and catalytic impact, meaning that the whole is greater than some of its parts, so that with the collective impact of multiple activities occurring at once, hopefully we may be able to make some progress into reducing suicide in the future. And in our space, we have really strong community representatives that sit on leadership groups in a community network model, and it's great to see some people that have participated in our trials here in this audience. Yeah, we're really great. Those organisations and people with lived experience and peer-led workers that offer a really important perspective about how we learn to do things better. So terrific to see those activities occurring in other areas as well.
Great, Michael. Thanks. I think we got most of that. You're breaking up a little bit, but I think we got most of that. Rachel, did you remember your 1 point or anything?
I did remember my point, but I looked it up in my PowerPoint that I guess like one of the things that I personally found very challenging was that when I was giving some of that health information in the presentation, so we had our speakers like Wayne Schwass, and we did have Danny Frawley, and so may he rest in peace as well. What I found challenging was actually presenting to a completely different audience that wasn't a health audience, and I think that to me was something of worth to remember, is that we're as a PHN, we're often used to, you know, preaching to the converted, or, you know, engaging with people that we kind of know they get it, or we know that they're engaged. But this was like, I can't read this crowd, like I you know, use some examples like a Winston Churchill, The Darkest Hour kind of vignette from the movie, and sort of some of those things I had to readopt of what do I actually present and how do I do that best, because I'm so used to a different type of audience. So that would be my own personal reflection out of all of this. Yeah.
That's great. Yeah, one of the common phrases you hear in the men's health space is the value of meeting men where they are, and you see some examples of that in all of the talks, because that's both about actually, you know, going out to places where men already are, or creating the kinds of spaces where men are more likely to show up. But it's also about, it's not just a physical thing. It's not just about, you know, going to a workplace or going to a farmer's market or creating like a lunch. It's also about meeting them where they are psychologically, or like when Mick was talking about them showing up angry, right? It's like meeting them at that point, not meeting them at the point where you hope to meet them, which is saying, I feel suicidal and I want to talk about my feelings. Not many men show up at a service with that opening gambit. And yeah, we have all that stuff around, yeah, and that's true for any population, right? It's trying to work out where they are in the conversation and how we can make our conversation overlap with their conversation. And so, yeah, and getting us to explore that. And there is no one size fits all, but just having that in our mind, it's like, how can we have this really important conversation with this person or this community in a way that's actually going to work for them? Yeah, so it's a good question to keep asking ourselves always, I think. Chris?
Yeah, so probably the big one for me across all of the presentations and just generally this event is just capitalizing on that that momentum that I spoke about in my presentation. So I think, you know, the need that we've all sort of gathered to talk about isn't a new one. It's one that's been here for some time, but it kind of feels like now in the last couple of years, the momentum's starting to shift where, you know, the right types of projects are converging, the right types of conversations are happening, and just the passion that the people are showing for this topic is resulting in the right level of action. So it's just really heartening to see. Like I said, I feel really privileged to be part of it, and to be able to work in the PHN in the way that we do. So yeah, I think it's probably just a call to keep that momentum going and to support probably a lot of the work that Glenn and his organisation are continuing to spearhead.
Right. Well, thanks, Chris. In a moment, I'm going to open the floor up. I'm going to ask you. Some of you have got a hand up, probably from earlier when we were asking you to put your hand up from where you were around the country. So I'm going to ask you, especially Anthony, Ashton, Andrew Humphreys, Angeline, Greg, Deb. Can you actually just put your hands down for now? And so I'm really clear that you're putting your hand up when I ask you in a minute. And that means you need to go to the participants icon at the bottom, click on that, and just make sure your hands are lowered, because in a moment I might ask for raised hands and I want to see them fresh, so we're really clear that you're not just saying hello. And just Jacki, to come back to you first.
Yes.
Yes.
I think being so isolated from sort of the East Coast, it's really, from these presentations, it's really good. I'm really gratified to know that I'm not doing anything totally different, but we're all sort of pushing in the same direction with this dreadful topic. Well, not dreadful topic, but you know what I mean, dreadful outcome. But yeah, it's very gratifying to know that what we're doing here in the Midwest is being done similarly around Australia. Basically, that's what I'm trying to say.
Well, yeah, thanks for being here, Jacki. I know being out in WA can feel like a million miles away from what's going on in other parts of the country. So it's good to be able to connect you to work in the New South Wales and Victoria is right now, and of course all the other areas that are represented today. Thanks for being here. So look, officially our panelists, you've given a good chunk of time and you're very free to go now. So I'm going to officially thank you all for giving your time and contributing to such a really interesting session to start the day. And you're also very welcome to stay. The next session will start officially at 10:45. So this is at 11:45, sorry.